Dr. Ramani.
Good morning. Now, anybody, this is a colossal water body, Pangong Lake, high up in the mountains in Ladakh. And when you see it from a distance, it gives you an impression of serenity, calmness, but when you go closer, when the waves come and lap at your feet, you know that there is a lot of intense energy and dynamism inside. And that pretty much sums up our orator today. It all started on the Independence Day in 1951, when the star was born. So put your hands together once again for Professor Benjamin Joseph. Senior pediatric orthopedic consultant, Aster MedCity, Cochin at present, but was a former professor of orthopedics, Kasturba Medical College, Manipal University, India. Formal head of the Pediatric Orthopedic Service, Department of Orthopedics, Kasturba Hospital. Started his schooling in Uttakamand and Hyderabad, got an India Merit Scholarship, and later on joined Vellore for his training in medicine, MBBS, with proficiency certificates in most of the subjects. Got AC Ashirwad, another memorial prize for the Madras University for the performance in final MBBS examination. Post-graduation ranker, first ranker in Kasturba Medical College, Manipal. Kasturba Medical College, Manipal, MS Ortho, first ranker. University of Liverpool, first ranker. After diploma in orthopedics, distinction in Master of Surgery. Kaza Nifar Medal in University of Liverpool for the best clinical performance in MCH Ortho exam. Examiner's Prize, University of Liverpool for the best all-round performance in the MCH Ortho. Training in pediatric orthopedics in Sheffield Children's Hospital, UK, and Alderhayes Children's Hospital, UK. Outstanding academician. Publications, 101 papers in peer-reviewed journals, chapters in 5 textbooks. Pediatric authors of textbooks, Pediatric Orthopedics, A System of Decision-Making, Pediatric Orthopedics Diagnosis, editor in Orthopedic Clinics of North America, Perthes Disease, and editorial and a part of the editorial board of Journal of Pediatric Orthopedics, Journal of Pediatric Orthopedics B, Journal of Children's Orthopedics, and was principal investigator in projects funded by DST, Indian Council of Medical Research, Ministry of Welfare, Government of India. I enjoy finding simple and cost-effective ways of treating complicated problems and have tried to innovate. Oh yes, he did. Surgical innovations in clubfoot, cerebral palsy, pseudarthrosis of tibia, special interests in orthopedic aspects of neuromuscular disorders and congenital anomalies. And believe me, this is all just the tip of the academic iceberg. Dr. Benjamin Joseph, one of the key founder members of and a visionary for Pediatric Orthopedic Society of India, POSI, and his various moods in earnest, being relaxed in the OT, and intense, being intense while delivering and interacting during conferences, and most important, his students just love him. And sir, you command respect and we salute you. So with greatest pleasure and utmost, can I please request Dr. Benjamin Joseph to come and give his oration? Can I please request for a standing ovation for this great teacher?
Thank you. Thank you very much. Ladies and gentlemen, I consider it a singular honor to be invited to deliver the POSI Oration 2018. The title of my talk is Tulabharam, the balance sheet and the accounting equation. Sounds like Greek to most of my foreign visitors. I'll start off by giving you some Indian statistics. A lot of it is not entirely flattering. The infant mortality rate in India is 34 per 1,000 live births. 93% of children enroll in primary school, but when they get to standard 11, only 52% are enrolled. Simply because an estimated 47 million children of secondary and higher secondary school drop out. Higher education in India, less than 18% actually enroll in higher education. If you take the undergraduate medical education, 93% of students who apply for the course don't get in. If you compare the acceptance rate into Harvard and Vellore, you can see that the acceptance rate in Vellore is much lower. Of those who've graduated into the medical course, very few of them, less than 8%, succeed in going on to a postgraduate course. Extremely few people have the opportunity to train and specialize in some specialty in orthopedics, particularly abroad. And this calls for some introspection. Where are we now and how did we get here? Well, we are here. We are members of POSI, extremely respected practitioners of pediatric orthopedics, members of a fantastic society, which is unique in this country and respected even abroad. How did we get here? We survived through infancy and childhood. We had the opportunity to go to school. We didn't have to drop out of school. We could go to the university. We could enroll in a medical college. We could train as orthopedic surgeons, specialize in pediatric orthopedics. Some of us had the fortune, or good fortune, of interacting with leaders across the world. And some of us were even more fortunate to collaborate with colleagues across the globe. So undoubtedly, each of one of us is among the most privileged in Indian society. And it is something that we should never forget. I would go on to say that while we may have very legitimately earned the position that we are in, we have to admit that there are many more deserving persons in the community who just happen to be less fortunate than we are. At least in some small measure, each and every one of us are beneficiaries of opportunities that have come our way thanks to societal disparities. Not just simply because we deserved it. And therefore, I believe that we owe to society tangible efforts to repay some of the advantages that we enjoy. As orthopedic surgeons and as pediatric orthopedic surgeons, how do we repay our dues to society? Obviously, offer a clinical service, teach, and do research. But I would qualify this a little more. We need to offer a clinical service that's accessible to the poorest child in the community. We need to teach in such a way that it leads to improvement care of our children and society in the community. And our research should be relevant to improving the care of children in society. Let's take each one of these in a little more detail. How can we offer a clinical service that is acceptable to the poorest of the community? We need to give up our time, our energy, and money to make this possible. Some years ago, I had to give a talk on childhood disability. And I downloaded this image from the net. And it's haunted me ever since. There were three messages that came across extremely loudly from this image. First and foremost is the indomitable spirit of this young boy who, despite physical limitations, whacks that ball with gusto. The second is the inclusiveness of the able-bodied youngsters who included this unfortunate child in their game, despite the fact that it would have slowed down the proceedings. But the third message is less laudable. It is an indictment of us, the pediatric orthopedic community, that our treatment has not reached him. And that is the focus of this talk. It is easy for us to say that we're extremely busy. we are working in an environment where we don't come into contact with the poor, maybe working in a corporate hospital. We may say that we are too busy. We don't have time to really devote time to finding out the poor and helping them. But the legacies of people like Noshir Antia should prevent us from doing that. Noshir Antia was a plastic surgeon in Bombay, and many of you would have heard of him. He was an outstanding plastic surgeon who headed a huge department in Bombay, did outstanding research, published a lot, did work on leprosy, gave Hunterian orations, but still had time to do community work in the districts of Maharashtra. If he could do that, there is absolutely no excuse for us to say that we don't have time. There is time. We may say that we are too far away, but I just think in terms of a couple of three institutions in Tamil Nadu, which I've taken as examples. Ashwini, which is a small hospital in Gudalur, which is exclusive for Adivasi patients. The Tribal Health Initiative in Chittilingi in the Dharmapuri district, which deals with tribals. The Gandhigram Institute near Dindigal. These are just three examples of places that I've come into contact with, where you will have the opportunity to treat the poor and the needy. What prevents us from spending a little time each year on a regular basis in institutions like this in every state, in whichever state you come from, to offer our services to those who need it most? The next thing that I would say is we need to resist consumerism and do it absolutely with fervor. Consumerism tells us to spend freely and even to waste creatively. Can you imagine that? Creative wastage? Because businesses have realized that the wealthy consumers are the most attractive targets of marketing. Because emulation is an essential component of human nature and of consumerism. Consumers seek to emulate those who are above them in social hierarchy. And therefore, the upper class tastes and preferences will trickle down to become the standard for all consumers. If you walk into any city in India, you will find youngsters, large proportion of youngsters wearing jeans. And jeans was never outfits that Indians normally wore. It is a Western outfit. And because that was the in thing, we have all imbibed it. I'm just using it as a simple example. And this is what we would all do. And this is true of orthopedics. The tastes and preferences, both good and bad, that's important, of orthopedic surgeons in the Western world will trickle down to become the standard of all orthopedic surgeons, including those of us in the developing world. Some years ago, India produced a car which was touted as being the cheapest in the world, the Nano, which you see on your left. And in an automobile magazine which came out that year, showed a car which is shown on the right, which is apparently the most expensive. I'm not sure whether that's true, but nevertheless, a very expensive car and a very small car shown side by side. But irrespective of the cost, both are cars. They are vehicles for conveyance to go from place A to place B. It hardly matters what the cost is. You may even embellish your car with gold, but it still remains a car. The function is exactly the same. And this brings us to some simple orthopedics. This Blount staple made of stainless steel of 1950 vintage, around the time when I was born, with Walter Blount. The Metasor screw and the titanium 8 plate all perform the same function. And there are studies which show that when they compare the 8 plate versus staples, there was no difference in the rate of deformity correction. Complication rates were similar. Both were equally effective. In the developing world, which would you choose? Similar elastic titanium nails compared with stainless steel elastic nails. Now, the studies from the USA, not from anywhere else. from Cincinnati. The complications were greater with the titanium nails and less with the stainless steel. This brings me to the tourniquet. Two important studies showed that all sample tourniquets were highly contaminated with pathogenic organisms, which could potentially lead to surgical site infection. And the recommendation, therefore, was that this should become a single-use device. And the manufacturers jumped on it and put a label, single-use only. Right? However, in the same paper, if you follow it a little more, it says that on cleaning the tourniquets with the disinfectant wipes, reduces the bacterial load by 99%. 99%. Right? This fact is thrown out of the window. You can say that it doesn't matter about the tourniquet, you wipe it and use an occlusive drape, which separates it from the operation site. But the argument raised is that even if it's so-called occlusive, after 1.5 hours, it may become ineffective. So these are the arguments. So you have, say, use disposable tourniquet. If these arguments continue, one wonders when you will have to have disposable operating tables. And don't think that that's too far-fetched, because a study done in 2016, just 1.5 years ago, looked at bacterial contaminations of various things in operation theater, like the bear hugger, the operating table, the handle lights, electrocautery. Each and every one of them was contaminated. So it's anybody's guess. Are they going to recommend disposable operation theaters or just wipe it down? A year before I retired from my academic position, I did a tally of the number of operations that I would have needed a tourniquet. It came to 1,500. Now just imagine disposing of this, right? So, it just baffles me how advice comes in. So resist consumerism. The next is prioritize the needs of the community. If you had resources for one operation on the foot, or to treat one condition of the foot, would you go for treating a club foot or an asymptomatic flexible flat foot? I think we need to think deeply about where we're going to put our resources. I had the good fortune of designing the logo of POSI. I started with putting the Ashoka Chakra to show that it's Indian society, the Nicholas Andrew tree to show that it's an orthopedic society, and showed a girl, underprivileged in our society, walking with a hand-to-knee gait because of paralysis quadriceps, holding on to the stump of a tree in the form of a 1, to imply that the first priority at that point in 1994 was to eradicate polio. Right? Because 1995 was given as the target of WHO to eradicate polio. We didn't achieve that, but anyway, that was the aim. The same year, this boy walked in. Should I say walked in or crawled in? He walked in on all fours. He is from Tirupur. And with very limited surgery and bracing, he walked out. We must never forget that we're working in a country with limited resources, and that 60% or more than 60% of our people live in rural India. And when you encounter patients with problems and you have very little money on hand, one may hope that we'll have access to divine healing, but we need to be pragmatic. We don't. So what are the strategies for coping with limited resources? We need to innovate. We do need to innovate. A process is made out of high-density polyethylene irrigation pipe for a child with amelia. Extremely cheap, functional. And I think we need to emulate people like Dr. P.K. Sethi, who designed the Jaipur foot, which withstood the roughest terrains. We need to adopt new cost-effective methods. When telescoping rods become too costly, we adopted dual rush rodding. And I've mentioned in previous talks that they were comparable in terms of efficacy. An example. It's important to retain old and tested methods that are cheap. Cerebral palsy, spastic inversion. You can treat it with Botox. You can also treat it with 40% alcohol. Don't be shocked. This was reported in the Development Medicine Child Neurology Journal, which is the journal of the AACPDM in 1980, and largely ignored. A severe flexion deformity following polio, treated with soft tissue release and traction. Don't forget these old methods. They work, and they are cost-effective. A deformity of this nature, well, could be elegantly treated with a complex, fancy device like that, but equally well with just acute correction, osteotomies, cross-K wires at 2 levels. We need to follow principles, but don't hesitate to modify specifics. If you want to use an 8-plate, you don't need to go for titanium. You can take a recon plate, cut it, and use it. And it works. It certainly works. Most importantly, avoid wastage. We cannot afford to waste resources. When we had children with osteogenesis getting pamidronate, many of our children are so small that the vial has too much of drug in it, and you just have to throw it away. So we bring all the patients in at the same time, on the same day, add up their weight, get the exact requisite amount of drug for all of them together, divide it and infuse all of them one after the other. We saved a phenomenal amount. And it's important to evaluate our outcomes because we're deviating from the straight and narrow path laid down by our Western colleagues. The next is, so I've just touched on clinical service that's accessible to the poorest. The next we'll go on to teaching that leads to improved care. One of the ways of acquiring theoretic knowledge, at least in our time, was to browse through books, go to the library. Now it's a hell of a lot easier. With the click of a button, you get a lot of facts. The second is an acquisition of motor skills, which over a period of time, you can train anybody to become a surgeon. Right? With repeated practice, I think we all learn this. But I think, to my mind, learning the art of clinical decision-making is probably the most difficult. And it's important that all 3 of these form the foundation of our practice. So clinical decision-making is difficult in pediatric orthopedics because the consequences are far-reaching. And it's even more complicated when literature tells us different ways to treat conditions. How does one make the correct choice? Which option should one choose for a particular patient? What governs the choice of a particular treatment? I believe that often this decision-making is not taught well enough during our training, and sometimes not at all. Consequently, I think the foundation is weak, and you would agree that any edifice, the foundation is probably the most important. And clinical decision-making, to my mind, if I look at what happens, is too often a toss of a coin, and that is unacceptable, and this results in wrong decisions. I'll give the example of a child with septic arthritis in a neonate. The child was in an intensive care unit, neonatal intensive care unit. Low birth weight baby was on IV antibiotic for septicemia. On the 10th day after admission, diminished movements of the left lower limb was noted. The pediatric orthopedic surgeon on duty went and saw it. A diagnosis of septic arthritis of the left knee was made, and arthrotomy and washout was performed. The outcome was excellent. However, the diagnosis of a concomitant septic arthritis of left hip was missed, recognized only later. But then we said, well, since antibiotics that were effective against the bacteria isolated from the knee were being administered, it was assumed that there'd be no problem in the hip. Right? Drainage of the joint was not done, and we were wrong. the femoral head was dissolved. Inappropriate decision-making has resulted in lifelong disability. So can clinical decision-making be taught? I think it can. We need to teach people to identify problems that need to be addressed. Break it down, to analyze it, and identify problems. Define specific aims of treatment. List treatment options. List the relative merits of each option. List the factors that need to be then taken into consideration for making a decision. And then plan a treatment strategy. For every clinical situation, I think we can do this. Let's take the example of proximal focal femoral deficiency. Let's assume that of all the problems that are identified, let's assume that 2 of them have been dealt with already, to make things simple. Let's assume that we've decided that we're not going to do limb lengthening, we're going to give a prosthesis. And for instability of the hip, let's assume that appropriate surgery has been done. Now you're turning attention to instability of the knee and what do we do to the foot. So we now define our aims of treatment. We need to provide a stable thigh segment by overcoming instability at the knee, and we need to provide the most suitable prosthesis. So what are the treatment options? Well, the first and foremost is a vanless rotation plasty with a knee fusion. Right? Diagrammatic representation, and a beautiful example of an image sent to me by the late Ian Road. Lovely result. Foot in the prosthesis. Below knee prosthesis fitted. The second option, you could do a new fusion, knee fusion, Symes amputation, again, given above knee prosthesis. Again, one of Ian's patients. You might ask why I didn't use my own examples, because I don't have any of them. My examples are these. Because the parents refused amputation and the VANness. So give an extension prosthesis. Now look at the merits of each option. VANness, the most energy efficient prosthesis, because it's a below knee prosthesis, and the knee stability is restored. Option 2, knee fusion and Symes amputation and AK prosthesis, that's the second most efficient prosthesis. Knee stability is restored. Option 3, knee fusion, retain the foot, give an extension prosthesis. Well, it's the least efficient prosthesis. Now we need to list the factors that need to be taken into consideration: medical, social, and personal preferences. Will the child and parents accept surgery that turns the foot backwards? Will the child and parents accept amputation of the foot? Does the child come from a society that considered it inappropriate to enter a house or place of worship with footwear? Having said so much, what shall we do for this child? Option 1, 2, or 3? Well, it's not a fair question because I haven't shown you the whole picture. There are major transverse deficiencies to the upper limb. The feet will have to perform the prehensile functions of the missing hand. So in this situation, there are demerits that we need to consider. If you do a VANness, the prehensile function is lost. If you amputate, there's no limb to do prehensile function. If you fuse the knee, you're in trouble. Right? So a fourth option is now added: no surgical intervention of the knees or the feet. So we need to ask, among questions to ask, factors to be taken into consideration. What's the functional status of the upper limbs? So we now formulate a strategy. Upper limbs normal, parents and children willing to accept foot turn backwards, do a VANness. Upper limbs normal, parents willing to accept an amputation but not a VANness, do an amputation. Upper limbs normal, parents not willing to accept either a VANness or an amputation, do any arthrodesis and give an extension prosthesis. And finally, if the upper limbs are absent or non-functional, don't operate on the knee or the foot. So we need to teach our decision-making experience to our junior colleagues. And we never know how far this will influence people around you. With the hope that it may be of one source of learning, I plan to hand over all my lectures at some time to the Secretary of POSI to be stored in a repository and made freely available for anyone who would like to use them. Right? My wife, who's here, has on many occasions said, if you want to give something, give it away before you're dead or you're demented. You see? You're laughing at me. You think I'm demented. Anyway. Okay, now we're coming to research relevant to the community. Why do research? Not for the heck of it. Because if you do research just for the sake of doing research, it's like this staircase in a house called the Winchester House. It leads to nowhere. If you climb up, all that will happen is you'll bump your head on the roof. Why the staircase is there, I don't know. And research shouldn't be done just for the heck of it. Research should have a purpose to understand disease process, to develop treatment guidelines that are appropriate to a local situation, to influence a practice in orthopedic surgery, and the bottom line is to improve care that we give our patients. And for that, research needs to be rigorous, meticulously planned and executed, must stand up to critical peer review, and be scrupulously honest. We have been fortunate that over the years we could do epidemiological studies, studies on natural history, treatment guidelines, and outcome evaluation. And it's important to remember that over 90% of the papers that we published were on studies that were done without any funding whatsoever. So giving the excuse that we don't have funds, therefore we can't do research, is just not valid. All right? I admire those who do basic research and translational research. I haven't been fortunate enough to do it. And I salute Vrisha and her team here who've done pioneering work at the cutting edge. Congratulations. So, research that has facilitated a change in our clinical practice, that relevant to society, we must think in terms of. I can give you one example. Flexible flat foot. In my training, we were told if the parents bring a child to you with a flexible flat foot, give them some shoe, insert or modify their shoe. And the old Liverpool teaching of using a crooked and elongated heel and modified shoes and all was suggested. Now, many of our children who come were not normally wearing shoes, so we give them a pair of shoes with these shoe modifications or inserts and say, use that. Till some years later, we did some studies related to the influence of footwear on the prevalence of flat foot. We classified the foot forms in terms on the basis of footprints, and then showed that the prevalence of flat foot was considerably less in those who didn't wear shoes as compared to those who wore shoes. We followed this up with a second study. We looked at adults and asked them when they started wearing shoes. And those who started wearing shoes later had a much lower incidence of flat foot. There clearly is some association with early shoe wear and flat foot. In that, keeping that in mind, for a country like ours, which is hot and humid, it seems a little out of perspective to prescribe modified shoes and footwear for flat foot. Right? We've changed our practice. We don't prescribe that anymore. So in repaying our dues to society, I've touched on how we can do some of these things. And that brings me to the title of my talk, Thula Bharam. Thula Bharam was a very successful Malayalam stage play written by a man called Thopil Basi in 1968, later made into a very successful movie as well. But I'm alluding to an ancient Hindu ritual which has been practiced for several centuries. And in a temple in Indonesia, made in the 18th century, you can see that, a closer up of that. What it is a person is weighed in a balance and makes an offering to God in equal the weight of fruits, grains, or coins when one's prayers are fulfilled. So I can imagine that maybe this was an infertile couple, for example, and at last a baby is born, so they promised that they would give something to the temple, and this is an example of something like that. In December 2006, an industrial gave 70 kilograms of gold for Thula Bharam as an offering in Guruvayur temple. It was the biggest gold offering ever at that point of time. And he said, my business has reached such heights that with the blessing of the Lord, that it is my humble gratitude to the Lord. It was payback time for him. And we need to pay back to society. We're poor in accounts, at least certainly I am, and I think many orthopedic surgeons are. And we talk of what is a balance sheet, and accountants have a balance sheet which lists assets on one side and liabilities on the other. And what are our assets? I listed them. We are exceedingly fortunate. And what are our liabilities? not providing a good service, not teaching adequately, and not doing relevant research. I subscribe to the concept given in the parable of the talents in the Bible, which suggests that to those who more is given, more is expected. And we have been given a hell of a lot. The accounting equation calculates the net worth of a person by looking at the assets and subtracting the liabilities from the assets. And I ask you, what is our net worth? At the end of our career, will society have the opportunity to say to each one of us that we are worth our weight in gold? I wonder whether the Englishman who coined that idiom had seen Tulabharam. I don't know. Or will we be satisfied in being weighed against bananas? I can summarize the entire talk with the words of the chorus of a devotional hymn which says, "Freely, freely you have received, freely, freely give." Okay? Thank you very much.
Thank you, Dr. Benjamin Joseph, for that very inspiring and at the same time very humbling and inspiring talk to tell us that we have to give back to society what we have received. And I have with us here something that I'd like him to receive from us as a mark of our gratitude for being the POSI Orator this year. And I have a plaque which says, "The Pediatric Orthopedic Society of India honors Professor Benjamin Joseph for delivering the 10th POSI oration on the 18th of January, 2018, at the 24th annual meeting of the Pediatric Orthopedic Society of India, held at CMC Vellore, India." And I request our president, Professor Dr. Ramani Narasimhan, to hand over this plaque to our orator.